Hello, I appreciate the opportunity to speak today at the ACA this year. Thank Mackenzie for all the work she's done on the meeting, and thank Bob for the invitation to speak. Dr. Peets has been a wonderful mentor to me for many, many years, and just really appreciate him. My name is Kent Bashford. I'm an ophthalmologist in Fort Collins, Colorado. Uh, Fellowship trained in glaucoma and do cataract surgery as well. Today I'd like to talk about lowering intraocular pressure with cataract surgery. Here are my financial disclosures. So we know that cataract surgery alone lowers intraocular pressure. There's been a number of trials. Here's one from Lille out of the UK, where they did a large database review of 20,508 eyes in 8 sites in the United Kingdom. And they found that normalized that had cataract surgery had about a 1.4 millimeter drop in intraocular pressure. And those with glaucoma had about a 1 millimeter drop in intraocular pressure after cataract surgery. The pivotal MIGS trials have also demonstrated a decrease in intraocular pressure after cataract surgery by itself. Of course, our control groups in these trials were cataract surgery by itself. It's interesting, on these 3 large trials, CyPass, iStent inject, and the Hydrus trial, that they showed about a 5.3 millimeter of mercury lowering of intraocular pressure after cataract surgery by itself. These trials had similar protocols, similar inclusion and exclusion criteria. They were really designed very closely to each other. And so this is kind of neat to see how closely they are. Really makes it, you think we really don't need to maybe add control arms for some future trials. And there are some trials that are going on and trying to get it through the FDA to not use a control arm. So my objectives today are to talk about lowering intraocular pressure with cataract surgery. And I really want to discuss 2 different ways of this: trabecular bypass. These have the most evidence to them, these devices. They have high safety profiles. But I also want to talk about trabecular meshwork opening and removal. These also have been shown to be effective at lowering intraocular pressure. They may carry a little bit more risk to them, a little more destructive. So of course we want to increase the natural outflow as we do these. Through the trabecular meshwork, through Schlimm's canal, through the collector channels, and then into the episcleral venous system, which we know has a pressure of about 8 to 10 millimeters of mercury, which of course is very protective in these surgeries against hypotony. Let's see, trabecular meshwork procedures. We've got canal stenting procedures, the iStent inject, in particular the W, which was just released and we have access to now, and the Hydrus. I'd like to talk about those, and then also goniotomy, the Cahook dual blade, and the Omni device. So the iStent inject, of course, the original iStent was the first MIGS device approved by the FDA years ago, and it kind of paved the way to many ideas and thinking about how we can improve our intraocular pressures in conjunction with cataract surgery, but more importantly through the natural outflow pathway in a safe, effective way. The Glaucos iStent inject, of course, we implant 2 of these, ab internal through trabecular meshwork into Schlimm's canal. We think that they will open flow for about 1 clock hour each side. So we like to put these 2.5 to 3 clock hours apart from each other to maximize the amount of flow we get from them. The iStent pivotal trial was published a few years ago. Make note that Dr. Sarkissian, who just spoke to us, is on this paper. Great that he was part of this paper. And this study group, it showed that at baseline, we're unmedicated. These patients averaged about 24.8 millimeters of mercury. At month 24 after having their stents, they averaged about 17.1 millimeters of mercury. If we look at this graph here on the left, we see how many reach their primary endpoint of 20% reduction of intraocular pressure. That's a washed out pressure. And we see that with the eye stent, about 76% achieved that, whereas only 62% of those with cataract surgery alone achieved that 20% reduction. On the right-hand graph, we've got 7 millimeters of reduction of those that received the eye stent inject versus 5.4 that had cataract surgery alone. So overall, about a 1.6 millimeter mercury increase in IOP lowering with the eye stent inject versus cataract surgery alone. One of the great advantages to these devices is certainly the safety. After doing many glaucoma procedures and seeing all the complications, the safety of these is what attracts all of us to the MIGS devices. And if we look at these, if we look at inflammation, vision loss, IOP spikes, goniosynechia, all those things are very similar in these two groups, with or without the eye stent inject. And I'm confident in telling patients that we're signing up for cataract surgery that I really feel that we are not increasing the risk of surgery at all by adding an eye stent to what we're going to do at the time of their surgery. So recently released by Glaukos was the iStent Inject Wide W. It's got a wider base. For me, this certainly has made the implantation more consistent. It's a little easier to implant in the right place, primarily because it's more difficult to over implant this. The original iStent Inject, I would have a number of these where they would be a little over implanted and not sure how effective they were. My pearls for implanting the iStent W is to aim for that anterior trabecular meshwork. Avoid trocar bias. Try and make sure that that needle is right in the middle of that trocar as you pierce through the trabecular meshwork, and as you click to insert the iStent, that we don't inhibit the release of the iStent into the meshwork or into the canal at all. And I always try for a good 2.5, 3 hours apart, clock hours apart. And if that means, moving my chair and moving myself over here and implanting one, and then moving over here to implant another one, it's worth doing that, because I do think these are more effective if we put them a little further apart. Hydra stent, this was approved a number of years ago by Avantis, and it's a bypass stent with scaffolding. It's 8 millimeters in length, and it will stent open about 3 clock hours of Schlemm's canal. It's made of nitinol, a biocompatible material used in heart stents, and has been shown to be a great material. It's crescent shaped, so it allows it keeps any contact away from where the collector channels are, how it's shaped. It also has the windows that allow for a more complete flow of fluid through the meshwork and into Schlemm's canal to the collector channels. The Horizon trial is the big trial for the Hydra stent, and it's had a 1 year, 2 year, and a 5 year release of its data and information. This is a large trial, 556 patients put in it, about 2 to 1 were randomized, 2 to Hydrus for every 1 to phaco. So 369 in the Hydrus arm and 187 in the phaco only arm. It was mild to moderate open-angle glaucoma, patients on 1 to 4 medications and no prior glaucoma surgery. They were washed out at the beginning of the surgery and needed a pressure between 22 and 34 to be a candidate for the trial. Primary endpoint, again, is 20% reduction in washed out diurnal IOP at 24 months. We look at the data. The mean unmedicated IOP of the Hydrus was 16.7, whereas cataract alone was 17.5 after 5 years. And 66% of those with the Hydrus were medication free, and only 46% of the cataract alone were medication free. So if we look at this graph, this compares each year kind of the IOP reduction of Hydrus versus the cataract alone, and the orange bars there are the Hydrus. So if we look at that at 12 months, we're approaching that 9 millimeter mercury lowering, and 24, 36, 48, and 60 months, we see that we really maintain that IOP lowering throughout. Phaco alone also had a nice lowering of intraocular pressure that maintained fairly well throughout the 5 years. And after 5 years, it was about 6.5 millimeters of mercury lowering of pressure. The risk of glaucoma surgery is lower in those with the hydrous group, shown on by that blue bar there on this Kaplan-Meier curve. That we're about 2.5% chance of needing an interventional glaucoma surgery in the time of the trial. Whereas on the gray line there, we see that there was a much higher risk of needing a glaucoma surgery in that arm. Safety profile again for hydrous is extremely good. This compares the 2-year to the 5-year safety of hydrous versus cataract surgery alone. And if we look at the hydrous for a minute and look at, let's say, loss of the visual field greater than 2.5 decibels, 4.3 lost visual field at 2 years, and 8.4 were at 5 years. And with the cataract surgery only, it was 5.3 at 2 years and 9.6% at 5 years. So very similar to visual field loss between the two arms. Few obstructive adverse events there shown on that. And another interesting part of this is the corneal edema. We're all a little gun shy with affecting the cornea with our glaucoma surgeries, especially these MIGs. But we can see that with or without cataract surgery, 2 years, 5 years, doesn't matter. We were at 0.5% on all of those arms with these surgeries. So really no great risk to the cornea at all with getting the hydrous versus not getting the hydrous. Persistent inflammation also similar in the two groups. Hydrous, my take is it is slightly more difficult to place than an iStent. It has a tendency to dive if you don't have that angled right, and it will head south on you a little bit and into that suprachoroidal space. But the complication rate is still very, very low with this. We'll see a few hyphemas. Malposition is the biggest thing that I see with these, and they've struggled, to get these in the right position. You really have to pay attention and have everything set up right to get them in the right in the Schlemm's canal every time. Don't know the wrong long-term effects of having them not perfectly positioned. That maybe can be mildly disruptive. So my pearls for the hydrous are to make sure you get a good view. That's just critical on all of these, is to make sure your head's tilted, the microscope's lined up, patient's still, that you've got an adequate viscoelastic fill in the anterior chamber, that you're not losing your viscoelastic out your corneal incision. The other thing that I've done to help with this, a couple things, is I've actually made an incision clear off to the right, about a 1.5 millimeter incision before I make my cataract incision or anything, and I'll put the hydrous in through that so that I've got a more stable anterior chamber as I'm inserting this. Also, once in a while I'll take a 25 gauge needle and go through and just do a little goniotomy where I want to insert the hydrous. Take your needle, open that up, and you can push down on the lip. You can look right in there and see the wall of Schlemm's canal. That way you know that you're through all the layers of the trabecular meshwork when you go to insert the hydrous. Angle of the inserter is key. Make sure that you're angled up a little bit so that it's headed a little bit more toward the cornea. Not so much so that it bounces off the top and dives down on you. When I do this, I'm really careful on what I'm looking at. I get my inserter in place and I look at the inserter. And I start to wheel the stent into Schlemm's canal, and I look at that inserter, and I look at the inserter right at that insertion point. Then I'll check my windows, but then I'm back to the inserter to make sure that I've got that at the correct angle. iStent versus hydrous. Both of these, iStent, we place them 3 clock hours apart. The hydrous scaffolds about 3 clock hours. And there's been some studies as to compare these two as to which is better, which is more effective, and which is safer. The COMPARE trial was published a few years ago. They looked at 152 eyes with open angle glaucoma. They put a hydrous in or 2 iStents. They did a washout IOP to get into the trial between 23 and 39 millimeters of mercury. At 12 months, they had similar intraocular pressure lowering in the two groups. The medications were lower in the high-dose group. They were on average were on 1.0 med versus 1.7 meds for the iStent group. Goniotomy. Another way to help ourselves during your cataract surgery is to remove trabecular meshwork or open Schlimm's canal. And so let's talk about that, how we unroof that trabecular meshwork, get into Schlimm's canal, and help get fluid to our collector channels. Goniotomy is an old surgery. It's been around for a long time. We've got new techniques, new instrumentations, and it's nice that we can use the old codes. These are not required to be with cataract surgery, and there's no limit on mild, moderate, or severe glaucoma. We can do a goniotomy in most patients. Of course, a couple different ways I'm going to talk about goniotomy. One is the Omni with the catheter there in the bottom left. Kind of see that, how that works, and the dual blade, which has two blades which will strip the trabecular meshwork as you move along. So at KDB, it will remove trabecular meshwork tissue for 3 to 4 clock hours. We go in one direction and then flip it over and go the other direction. And this is another one where I don't mind moving my scope, moving my hands, moving my chair, making sure that I have a good angle so that I can get as many clock hours cleaned out as I can. El-Mallah did a study here where he looked at 12-month outcomes of standalone goniotomy with severe, mild to severe open-angle glaucoma. And we see that at 12 months, he had a 5.1 millimeter mercury lowering and a 0.4 medicine decrease. And also at their 86% of the eyes, majority of moderate to severe, avoided the need for more invasive glaucoma surgery during the postoperative period. And that's, of course, what we're trying to do with these MIGS devices, is to decrease our chance of needing to do a bleb or do a tube, those types of things. So we see these decreased with these devices. Some pearls for a KDB is, again, good view, good positioning. Angle the blade to avoid the posterior wall that you're not going to dig in. Sometimes you get hung up if you dig in too hard. Be prepared again to move your chair viewing angle to maximize the length of that incision. GAT, the gonioscopy assisted transluminal trabeculotomy, is an opening of the trabecular meshwork for 360 degrees. There's different ways to do this. Suture is a nice cheap way, but I really want to focus on the Omni device because it allows a viscodilation of Schlimm's canal at the same time as you right before you do your goniotomy. So we're able to put it in 180 degrees, and as you withdraw the catheter, it will inject viscoelastic into the canal. You can do the other side that same way, and then you can put it back in and then do a goniotomy. And you can dilate 180, 360 degrees. You can goniotomy 180 to 360 degrees. So some pearls of doing the Omni is to, again, you can open the TM with the inserter by dragging it back and forth. You can also use a 25 gauge needle, go in, open that, pull down on the posterior lip of the trabecular meshwork, and you can look right into the wall and give you a nice view to get in, to get the catheter into Schlimm's canal. Again, the view is critical like all of these. If you're losing your chamber, if you do a viscodilation and you start to lose your chamber, just go in and refill with viscoelastic before you go back in again and make sure you have a nice stable chamber. And again, angle that just a little bit anteriorly so that it goes up and it doesn't dive down. I find this to be a little more forgiving as to getting in the canal than, say, that a hydrus is. GAT, some studies on GAT and KDB. One study showed a 30% reduction in intraocular pressure with a GAT, about 9.2 millimeters of mercury, and a med reduction of 1.43. Another study, a different study about KDB, showed that 64% achieved a greater than 20% reduction at 12 months and 80% reduced by medications by at least one. So these are both effective ways at lowering intraocular pressures and decreasing the need for medications. Interesting thing about what is better and how much of the trabecular meshwork do we need to open? There's been some studies on these in the labs. Even Morton Grant worked on this back in the 60s. Showed us this. Here's a graph by Rosenquist. That's from 1989, where we look at how many clock hours you remove of the trabecular meshwork and how much resistance is eliminated. We see that if we remove around 3 to 4 clock hours, that we get, there's not much benefit in these studies to reducing a resistance by removing more trabecular meshwork. So do we only need to remove a little bit with the KDB and not worry about trying to get 360 degrees with a gap or not? There have been some trials. These are smaller trials, and I think this question is yet to be really answered. But here at the American Glaucoma Society in March, Kalern had this poster up. I thought I'd present here, where they looked at the Cahook dual blade and it lowered intraocular pressure by about 1.33 millimeters, whereas the Omni surgical system lowered it by 3 millimeters. And they both had about a half a medication reduction. So the percent IO change from baseline was 5.5% with the KDB and about 11% with the Omni system. Another study done by Hirabayashi that showed a 6-month trial with 74 eyes that the IOP reduction with the KDB and the GAT were about the same, right about 3 millimeters of mercury. And the med reduction was also about a medication per device. So when to add MIGS? This is a great question as to, what do we do with cataract surgery? When do we do one over the other? And there's a great deal of surgeon variability. If you talk to any glaucoma specialist, they're all going to have a little different take on this, and anybody that does MIGS, they'll have a little different take, things that they're comfortable with, things that they like, things that are easier to get paid for in their area. All these things come into play. What do we do with ocular hypertension? What do we do with glaucoma and how severe it is? All these are great questions to ask and to figure out. And we always need to remember to balance that risk and reward whenever we're treating patients, to know that we're helping them, that we're limiting the risk of complications and problems coming up. So I'll give you my take on some of this. So differences in my mind. The iStent inject, it lowers the intraocular pressure. I think it does. It's some, but it's very safe. I have no problem telling a patient, again, I am not going to increase your risk of surgery at all by doing an iStent at the time of your cataract surgery. Hydrus lowers IOP a little more. There is, I think, a little higher risk. There's a little bit of destruction risk with it, and a little bit of risk of it diving or not being placed quite perfectly. Goniotomy also, I think it lowers IOP a little more, but there's definitely tissue destructive with it by design, and we have a little higher risk of hyphema. Again, if I'm doing a goniotomy with an Omni device, I will try and stop blood thinners. If I'm only going to do a couple, 3, 4, 5 clock hours with a KDB, generally I allow them to continue on their blood thinners. So what do I choose? If I have a patient with low risk ocular hypertension, they're not on any medications, generally I'll go with cataract surgery alone, and there's certainly some overlap as I go through these groups. But really, if there's just not a lot going on here, we'll do cataract surgery alone and live another day to work on their glaucoma surgically if needed in the future. There are a number of trials going on now with standalone procedures with these MIGS devices. We've been a part of a number of those trials at our center and hope to see those approved soon. It's never really made sense to me why these were only approved with cataract surgery in the first place. But hopefully soon that'll be corrected and we'll be able to put these in patients that we think that they'll benefit. So what do I choose? Mild to moderate. Their pressure's controlled on meds or an SLT. I want to do no harm. Then those are people that I will put in an iStent inject W. If I have somebody that's mostly controlled, but I'm a little concerned about them in their life. The glaucoma might catch up to them a little bit, and I really don't want to do a subcon surgery, no bleb, no tube, that kind of thing. They're on meds. They have mild to moderate glaucoma. I'll do a hydrus. And this group does overlap with my iStent group some, and it overlaps with my GAC as well. But what I choose if we're more moderate to severe, I'm concerned that they're going to have some glaucoma trouble in their lives, some vision trouble, might have insurance issues with a stent, they're not well controlled, or they are controlled on meds, pseudophakic, those types of people I'll lean toward a goniotomy with a KDB or a GAT. So people ask me, how do I get started? What should I do to try and begin doing MIGS if I haven't done them before? And first thing, what I did and what I recommend is that you practice gonioscopy in the OR without performing a procedure. Do a cataract surgery, put some gonio viscoelastic on the cornea, turn their head, turn the scope, get a gonio lens, and look at the angle, and just get good at viewing that angle. And then, as far as a gonio prism goes, I use many different ones. TVG is one of the first ones I used, but the Swan Jacobs, there's some disposable ones that are out there, and they're all good. And I actually use different ones for different procedures. I kind of have a favorite one for each procedure, depending on, the TVG might press down on the canal in some cases, and some stents and things I'm not so worried about that, and others I am. And so try different gonio prisms, get familiar with them, and you'll find one that you like the best for each procedure. Recommend that you start with one MIGS, generally a KDB. I think is probably the easiest to perform. You're not trying to get a stent right in the right place. There's some leeway there as you get into the canal. And then add procedures as you become more comfortable. That's what I'd recommend. Well, I want to thank you for your time, and from Fort Collins, Colorado. I hope everybody has a great day. Thanks.